I welcome everyone for today's webinar. I'd now like to introduce our presenter for today, Laura A. Dixon. I'd now like to hand over the floor to the speaker. Over to you, Ms. Dixon.
Okay, well, thank you very much, Adam, and I'd like to welcome everyone to today's program. As Adam mentioned, we're going to be covering quite a few items for today under the conditions of participation. It has to do primarily with medication administration, but we're going to talk about IVs, and that includes blood administration. You'll hear quite a bit that we're going to talk about and how it involves nursing, because when you think about it, nurses are the ones who are really doing a lot of the administration, whether it's IV medicines, opioids, or even blood. So those are the things you never want to see, especially if, that's somebody you know, it's in your area. So let's start off talking overall about the conditions of participation and safe opioid use. Just real briefly, that's for those of you who haven't had the opportunity to listen to any other webinars. How do the conditions of participation come about? Well, the manual first came out in '86, and there have been, of course, multiple updates since then. What about Joint Commission? Some of you may be Joint Commission deemed status, and they have pain management standards that talk about opioid administration. Pain management is in leadership. Now, you think it'd go into medical staff or provision of care, but this goes into leadership. There are 7 elements of performance, and what you, of course, have to do is look for a leader, somebody who's responsible for that safe opioid prescribing. And this is a priority. Again, this is a priority not only for Joint Commission, but also for CMS. This requires a pain assessment and management as a priority for the hospital. Patients, they have to be also involved in their treatment plan. They have to be there to develop it. How are you going to do this? Are you going to participate? Can we rely on you? Will you be an active participant? Because the physicians can't do it all. This is really something the patients have to be so actively involved. And of course, that means realistic goals and expectations. You cannot expect a patient who has been on long-term opioid medication to just simply drop the ball and just carry on with their life. This is a very long process. Now, I understand also why they put it in leadership, because that's where it all starts. That's who makes the priorities, who establishes the priorities for the hospital. I want to move over to AHRQ, and that is the Healthcare Research and Quality. This is a great resource. Everything on there is free. So if you need something from it, you can get it for free. And they talk about acute treatment of acute pain and how, what's the evidence map that goes along with it. They have multiple resources on pain and pain management alone. And they put out a brief in October 2019 that talks about treatment for acute pain, and that does include non-medication intervention. So it looks at outcome from a multitude of types of pain, whether it's low back pain, post-op pain, or even dental pain. So it's not just limited to one type of payment. So it talks about not only acute pain treatment, but chronic pain treatment. There are effective healthcare programs through AHRQ. Again, you can download this. It is free to you. It also talks about the National Action Plan for Adverse Drug Reaction and how we can prevent them. This notes opioid is one of the 3 most common errors. And if you're wondering on the others, by the way, insulin happens to be one of them. And that can be very, very hard on patients who develop that cellular level of addiction. Now, these are not for patients who are in hospice. That wasn't the intent. These are for folks who have had, say, an injury or a surgery, and there's no clinical basis for the continuation of pain. Or they are just flat out have an issue with addiction to the substance. I'm going to diverse now over to CMS because they talk about opioids. And this is included in what they call the QAPI worksheet, the Quality Assessment Performance Improvement Worksheet. What they found is CMS, and they say this, medication is a shared responsibility of the nursing staff. So that means we have to use a comprehensive system to make sure we're in compliance with pharmacy standards and patient safety requirements are present under our QAPI. That's a major goal for those. So there has to be a risk assessment for our patients. We have to do monitoring of them on their, especially their response and opioids, so we can cut those medication errors. CMS, they updated their requirements so they are in better line with acceptable standards of practice. CMS will not establish the standard of care. They leave that to the professions, to the physicians, to the pharmacists, to the nursing. They do not establish a standard of care. I know sometimes you read those regulations and the interpretive guidelines and think, oh my gosh, that's what they're doing. But essentially what they're doing is they are repeating what the national standards are. They've also found that opioid-induced respiratory depression deaths might be able to be prevented. We do a proper assessment, a risk assessment, we monitor them. And by the way, PCA, that's a form of self-medication. This is what the QAPI worksheet looks like for adverse drug events and medication errors. Now, I've included the link to this worksheet. It's in the appendix, so feel free to go back there, get it, pull it up, work with it. You may have to type it into the search engine, because if you copy-paste, sometimes that doesn't work. So you'd want to type it in. There are 3 of them: QAPI, infection control, and prevention, and discharge planning. So all 3 of those links are available too. And by the way, when you are looking at this worksheet, you will see a tag number that is to the acutes, because they are not using the worksheets in critical access hospital. Not yet. Now, whether they will in the future, that hasn't been made public. But you can still use them because they're great resources, they're a great assessment tool, and you'll have an idea about what CMS might ask once they're on site at your hospital. ISMP, Institute of Safe Medication Practices, put out medication guidelines for us on doing IV push. The real impetus behind this, now we know we've had to monitor infection control, that's not news. But what happened in Nevada, and for those of you who are listening to this, you're probably well aware of this. This was our Nevada physician he was working in a GI lab, and he was trying to save money. And he was seeing multiple patients daily, but he still wanted to save money. And so what he did was he saved money by reusing syringes. And what happened here is that we started our day with a clean syringe, clean vial, clean needle. We draw it up and we inject a patient. Well, sure enough, that patient happened to be hepatitis C positive. And in the process of giving that injection, there was a backflow of the blood and serum into that syringe, contaminating the syringe. Now, the physician knew he wasn't supposed to do this. This was not news to him. He knew I wasn't supposed to do it. Well, unfortunately, he did it. And so now we have a contaminated syringe. He did throw away the needle. We give him points for that. But he continued to use that syringe. So he put on a new needle, injected, and went into the vial, which is now contaminated. And so now the vial is contaminated. So even if he had thrown away the syringe after the second patient, or the needle, he now has a contaminated vial. That was a multi-dose vial. And this process went on for a very long time, to the extent where thousands of patients were infected with hepatitis C. And so that's where we learned that we got to take stronger action when we're talking about IV push medicines, because we may not see it, but it's there. Okay, well, thank you everyone for attending today's program. We appreciate what you do for folks and for patients, and to stay safe. Thank you.
Thanks, Laura. So that does conclude the session today. Thank you everyone